Okay, good morning, everybody. Thank you for joining us today. My name is Chad Worley, physician liaison for Lurie Children's in the north side of the city and the north suburbs and the northwest suburbs. I just want to thank you for joining us today on this beautiful spring day as we introduce you to the Lurie Children's team from the Division of Orthopedic Surgery and Sports Medicine. For this session, we are introducing Dr. Romi Gibly, as he will be talking about lower extremity, rotational, and angular deformities, knock knees, bow legs, and intoing. Oh my. I encourage questions in the comments and questions section, and we'll answer those after Dr. Gibly's presentation. But before we get to Dr. Gibly, I would like to speak with you about the Division of Orthopedic Surgery and Sports Medicine. Lurie Children's is nationally ranked by U.S. News and World Report. We care for 30,000 children each year, providing a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. This is how we're able to recruit the finest specialists in the nation, such as Dr. Gibly. The Knee Injury Prevention Program, also known as KIP, is a neuromuscular training program designed to reduce the risk of ACL injuries among female adolescent athletes. KIP for Coaches is a free online training program to help coaches reduce the risk of ACL tears and other lower extremity injuries in their athletes from the ages of 10 to 21. In KIP training, coaches learn how to lead their athletes through a 10-minute warm-up routine that includes strength training exercises, plyometrics, balance training, agility drills, and active stretching. Our clubfoot program is one of many programs that are offered by the Orthopedic Surgery and Sports Medicine program. Clubfoot is a congenital condition that can affect one or more or both feet in newborns. You'll be able to hear more about clubfoot today at 5 p.m. with Dr. Laura Lemke. But now I would like to talk to you about Dr. Romi Gibly. Dr. Gibly is Lurie Children's attending surgeon and instructor for orthopedic surgery at Northwestern University Feinberg School of Medicine. He sees patients at the main hospital, Lurie Children's outpatient services in Lincoln Park, Grayslake, and Northbrook. Dr. Gibly completed his residency training at the University of Washington, Harborview Medical School, and Seattle Children's Hospital, followed by a fellowship in pediatric orthopedic surgery at the Children's Hospital of Colorado, where he acquired advanced techniques in pediatric trauma and fractures, foot and ankle, hip, and extremity deformity surgery. His clinical interests include pediatric and adolescent fractures, leg length discrepancy and deformity, club feet, hip dysplasia, and other congenital pediatric orthopedic diagnosis. I am going to give my kids those words to say as a tongue twister soon. In addition to this medical training, Dr. Gibly holds a PhD in biology with a background in bioengineering. Given this background, he is an active researcher with both laboratory and clinical projects here at Lurie Children's and Northwestern University. He is a member of multiple national organizations, including the Pediatric Orthopedic Society of North America, the American Academy of Orthopedic Surgeons, the Orthopedic Trauma Association, and the Orthopedic Research Society. Dr. Gibly was most recently awarded the St. Giles Young Investigator Award by POSNA for a laboratory investigation of the implications of electronic cigarette vaping on bone healing and bone metabolism, as well as grants from POSNA and the Skeletal Radiological Society with Dr. Jonathan Samet in the Lurie Children's Department of Radiology for working on developing a rapid MRI for diagnosing multiskeletal infections. But enough of this, enough of me talking. How about we hand it over to Dr. Gibly, who is going to tell you about his practice here at Lurie Children's and to discuss with you some common causes for pediatric orthopedic referrals. Dr. Gibly, I'm going to go ahead and give the screen over to you. I'll make you a presenter. Yep, give me presenter, and then you are good to go. Thank you.
All right, thanks, Chad. Can you see that all right there? All right. So thank you for joining us, everyone. We'll get this kicked off here today. I'm Romi Gibly. I am one of the pediatric orthopedic surgeons at Lurie Children's, and I'm going to talk about some of the issues that I think frequently come up for pediatricians and family practitioners. That is, questions about lower extremity alignment. So that's the lions and tigers and bears, oh my, of the lower extremity. So let's get started. I don't have any disclosures relating to this. I have a few grants, but none are related to this presentation. And if you have questions along the way, there is a chat box that I think Chad will be moderating, and this is my email address. You can email me today or whenever. So getting started with angular deformities, this is what we categorize generally as the knock knees and bow legs. Knock knees are generally considered genu valgum. Here's a nice picture for you guys. And genu varum is the bow legs. We see a lot of these in clinic. We as orthopedists have many ways to describe this deformity in terms of how we measure and calculate this, but probably the easiest way for you all to remember is something called the mechanical axis. This is a line drawn from the center of the hip to the center of the ankle, and you can observe where it crosses the knee. And this shows you sort of normal ranges being the center of the knee and becoming more and more outside the normal range the further outside the knee you get. One really important issue that we cover when we see children with bow legs or knock knees is whether it's actually a deformity or something normal. So as you notice, I put the age of these children here, and this is really important because as children grow, they tend to drift from a bow-legged position into a knock-kneed position and then back into sort of a normal alignment, or what we would consider normal for an adult. This frequently leads to kids being evaluated and then magically becoming better within another year or two. Here's another way to view that data. Infants, when they first learn to walk, tend to have a bow-legged posture. As they grow, they drift into a more knock-kneed position, which hits its peak usually around 3 to 4 years of age. Usually by 7 or 8 years old, they're starting to look more normal again. So what is the differential diagnosis when we consider a kid with an angular deformity? Well, when we look at bow legs, the vast majority of kids we see are really just normal kids, and some of that may be explained by their age. Then we have kids that fall outside the normal range or the expected amount of bowing for their age, and we call that idiopathic varus. Sometimes that needs treatment. More severe disease is known as Blount's disease, and this is a specific process I'll discuss in a moment. And then there are other causes such as metabolic bone diseases like rickets, skeletal dysplasias like achondroplasia. Internal tibial torsion is actually a rotational abnormality, but depending on how the child decides to walk, that can look like bow-legged behavior. And certainly children whose limbs have undergone previous fractures or infections can develop deformities. Similarly, for knock knees, a lot of these kids are just normal, but those that fall outside of the normal range, idiopathic valgus, and then other causes can include things like metabolic bone disease, skeletal dysplasias, and those post-traumatic and infectious causes. So this is an aside on Blount's disease here, also known as tibia vera. Generally falls into two categories. There's infantile Blount's. You usually diagnose this when the kids are young, often less than 5. These tend to be early walkers, and the deformity is usually seen on both sides. What you may notice is as they walk, the knee will actually shift to the side. We call this a lateral thrust. And if you get an x-ray, what you see is that growth plate looks very abnormal on the inner part of the upper tibia. This is in contrast to adolescent Blount's. Usually doesn't become noticeable until kids are in middle or high school. It's more often single-sided, although it can be on both sides. These kids are often quite large and way above their percentile for weight. And when you get an x-ray there, you see there is a lot of deformity, but the top end of the tibia looks pretty normal compared to that infantile Blount's. When we look at a set of x-rays for a child and we say, you've got crooked legs, one important question to consider is, do you have straight bones or crooked bones? And so if you look at the child on the left who has some genu valgum, you see that the actual bones themselves are pretty straight. Whereas the child on the right has genu varum, bow-legged, but his bones are not straight. And you can see there's quite a bit of curvature to the actual bones themselves. When you see a lot of curvature to the bones themselves, it should prompt you to consider things like metabolic bone diseases. Probably the most common of which we see is rickets. I won't get into a whole rickets lecture. That's more for the internal medicine folks. But that being said, crooked bones should prompt you to think about these things. What is not the answer for treating these is some of these topics I found on Google. Pump up knee braces, bananas, and even Forrest Gump's braces will not change your child's bow legs or knock knees. We're going to talk about a few more things, and we'll talk about how we actually do treat these. So, question for the group is, what kind of deformity is this? Well, we talked about this. This kid looks like he's in genuvarum. He's got some bow legs. That's great. Well, what if I told you he didn't have bow legs? This is with his feet pointing forward, and if you'll notice, his knees are kind of pointing out to the sides. If we actually straighten out his knees, what you see is that his toes point in quite a bit, and his legs now look straight. So this is actually internal tibial torsion. So the rotational difference of the lower leg causes the patient to walk with his knees pointing out to the sides, making him look like he's bow-legged. So sometimes that bow-legged deformity is actually a rotational deformity. And we do see a lot of rotational deformities. That's the in-toeing and the out-toeing. So put it first on both these categories, the most common thing we see with in-toeing and out-toeing is actually a kid that's just within normal range, but maybe a little off from what you're used to seeing. Other common causes of in-toeing are femoral antiversion, that is excess internal twist to the thighs, or internal tibial torsion, like the picture on the left. You can also have a deformity to the foot, most commonly metatarsus adductus, that leads to a curvature of the foot, leading to an in-toeing appearance. In terms of out-toeing, again, a lot of these kids are normal, but causes of out-toeing can be external tibial torsion, so an outward twist of the lower legs, as can be seen on the girl on the right. This can also be due to flat feet, which tend to spin outwards, or in some cases, even hip dysplasia. This is how we like to measure rotational deformities. It's probably easiest with a child lying on their belly, and you can see how far the femurs rotate. Now, this is a little confusing. This is actually external femoral rotation, and this is internal femoral rotation. As you can see, this young girl has a lot of internal femoral rotation, and she can get her feet almost flat to the bed. This is femoral antiversion. On the right here, you see how we measure the tibial torsion, or the rotation coming from the tibia. And that's looking at the alignment of the foot related to the alignment of the thigh. This image shows an external thigh-foot angle, which would generate an out-toeing type of position. And this is an internal thigh-foot angle. In terms of in-toeing, normal is obviously something we covered. The other major category we see, or the most common category we see, is probably femoral antiversion. We all know this girl who sits W all the time, and the parents or the mother-in-law is yelling at you, we got to do something. She's going to ruin her legs. She's going to ruin her hips. And you wonder, is this okay or is it not? Well, as far as the Department of Orthopedics is concerned, W sitting is okay. There is no good data to suggest that sitting in a W fashion is at all harmful for the hips or the rotation of those bones. We have families that yell at their kids for years about W sitting, and eventually it goes away and they can applaud themselves and all their family's hard work on getting the kid to stop sitting that way. But we know is that most of this just resolves with growth and doesn't really have anything to do with the position they choose to or not choose to sit in. The other most common categories are things like internal tibial torsion and metatarsus adductus, that curvature of the foot. In terms of out-toeing, again, a lot of these kids are just normal, but the ones that are outside that range may have external tibial torsion. They may have flat feet that tend to flatten outwards and make an out-toeing appearance. Or in some rare cases, hip dysplasia. Here's an example of an almost 3-year-old I saw last year in clinic. He came in for an abnormal gait. As you can see, the right foot swings outwards, and I flipped this image to help a little bit later. It's actually his left foot, but that foot is turned outwards, and he is leaning his body over that side of his pelvis, which is known as a Trendelenburg gait. And when we get an x-ray, you actually see that that hip was dislocated, leading to that deformity. So one other category that can be kind of confusing to look at, this is noted as miserable malalignment. This is a large amount of femoral antiversion, or internal rotation of the femurs, combined with tibial external rotation. So when she stands there, like in picture A, her feet point forward, but her knees point very far inwards. And what you see is, again, she can flatten those legs out on the prone exam, And when you look at her thigh foot angle, you see that her feet are pointing outwards quite a bit. This is a pretty unpleasant condition and can sometimes lead to operative intervention. Like our graphs for the bow legs and knock knees, rotational deformities change with growth of the child. And so often we see an excess of femoral antiversion in those young ages, that sort of 5 to 7 year old, especially in females, we see a lot of that. That often improves quite a bit with growth into the teenage years. And similarly, in-toeing from the tibia tends to improve significantly over those first 10 years of life. These aren't things the kids are going to grow out of in a year, but over several years they will. And in-toeing usually improves quite a bit with growth. Out-toeing is a little less reliable in terms of its improvement. One other big category I see is concerns about leg length discrepancy. In some cases, this is idiopathic, and large studies have shown that up to 1.5 to 2 centimeters of difference side to side might be normal when you look across the population. That being said, certainly history of fracture or history of growth plate fracture can lead to leg length discrepancies. Hip dysplasia can lead to leg length discrepancies due to a dislocated hip. Other more rare conditions like hemihypertrophy can lead to overgrowth of one side. Neuromuscular conditions like hemiplegic cerebral palsy can lead to shortening of one side. And then there are even more obscure diagnoses like tibial or fibular hemimelia or femoral deficiency that can lead to significant shortening. In the X-ray on the left, we see a relatively level pelvis, but that's because he's standing on about a 3 centimeter block. This kid has obvious deformity of his tibia and has a prior history of infection. In this image, you see the pelvis is quite tilted, and that's because this femur is short. You can see the tibias are relatively the same length. This is a girl I'll be treating later this year for a post-traumatic growth arrest of her distal femur. So a big question is often when to refer to us for these rotational and angular deformities. Here are a couple tips that may help guide you. Rarely do we intervene or need to do anything for children under 2 years of age. So generally you're very safe waiting a little bit. Especially if you have X-ray documentation of worsening, we should see the kid. In-toeing from a foot that is stiff or painful is worth seeing sooner rather than later. Leg bowing, so that bow-legged genu varum, could be concerning for Blount's disease and is probably worth seeing, especially if there's any asymmetry or unusual gait that goes with it. Most knock knees are not needing intervention. That being said, if they're very significant, bothersome to the patient, or the patient is starting to get into those older age ranges, it's probably worth seeing. Flat feet in and themselves rarely need intervention, but if they start hurting the child or causing other problems, it's worth seeing them. And certainly if you notice asymmetry side to side or a progressive pattern of worsening, we should see the kid. A brief bit on how we fix some of these deformities. There are some rare circumstances where we use some bracing to help control deformities, but the bulk of this is either letting the kid grow or doing a surgery. In some cases for younger children, the bone can just be cut and pinned. In other older, larger kids, plate and screws may be necessary to restore that deformity. This is a kid who had rickets. It was treated, but he continued to have deformity and so was corrected. Another common way we use to correct small deformities is what's called guided growth. We can do this by basically implanting a tether on one side of the growth plate. And what this causes is new bone to form only on the other side, slowly straightening out the limb. So here's an example of a kid with a lot of knock knee who had temporary hemiepiphysiodesis here on the distal femurs. And you can see that after about a year or two of treatment, they've straightened out nicely. And then we get to the topic that a lot of people like to hear about, which is lengthening. This is how we used to do this with a lot of frames. This is a lot of work with a very high complication rate and pretty big psychological, emotional, and practical time-based burden on the families. Luckily, we've had some developments that make this not so necessary. We do use frames in certain circumstances as they are very powerful, but we have some new technologies, including these growing rods, which are really fantastic for providing length to patients. So this is an example of a child immediately after surgery where we make a cut in the bone and implant one of these growing rods. They have a magnetic gear shift in them that allows that rod to lengthen over time, getting that child up to 4, 5, 6, or even more centimeters of length. This is a company called Nuvasive that makes these rods in the US, and this has really revolutionized how we lengthen patients' legs. They no longer have to have the large frames and pins and pin tract infections and all the issues that causes, and allows them to actually lengthen at home using this device that engages that gear shift over a period of weeks and months. This is an example of someone who similarly had a growth arrest and a significant length difference, and after lengthening has evened out. Just a very brief aside on club feet, since you'll hear more about these tonight. These are one to always refer without really delay. We can start casting as young as a week old, and honestly, the earlier we start, the easier the process is. And we are happy to see patients as a department prenatally when this is diagnosed in vitro, or excuse me, in utero on ultrasound. A couple quick notes on fracture imaging guidance. In general, you may hear people complain about the x-rays that were obtained, and that's often because one view can be considered no view, as one of my former chiefs used to say. So this is an example of a shoulder x-ray that doesn't look that unusual, but when you finally get around to the other view, you see this patient's actually dislocated posteriorly, and without that second view, you really wouldn't know. This can lead to missed fractures, missed dislocations, and other problems. This is probably better illustrated in pictures like this. We understand some optical illusions that make it look like a giant is squishing their friends, but others are less clear. How is this one child so much larger than the other? This is what's called an Ames room. It's a perspective abnormality that makes it seem like they're in the same plane. A second view of these scenes really helps clarify what is real and what is not. And fracture imaging is very similar. Another piece of guidance for fracture imaging: please obtain weight-bearing x-rays whenever possible. This is obviously an adult knee with arthritis, but the point is the same. When that patient is not weight-bearing, joint spaces look reasonable. Knee looks relatively well aligned. But when you make them stand up, you notice that this joint space actually disappears and they start to drift into varus. Here's another example of the feet. A non-weight-bearing foot demonstrates near normal alignment. But when you actually have that patient stand up, you see they have a pretty severe flat foot. So whenever possible, weight-bearing x-rays. Common question that comes up and concern from both families and pediatricians alike is, well, I don't really want to get all these extra x-rays because I don't want to radiate the child. And I think it's really important to have that consideration, but also understand the context of how much radiation we're really talking about. This is a bit of a busy slide, but we'll start with the basics. Each of these squares represents a unit of radiation exposure from flying from New York to LA, or about 1 yearly background dose of just living on planet Earth. As you can see, all these blue squares together are 3 green squares. So you can see that compared to your yearly dose, a flight from New York to LA is quite small in terms of radiation exposure. Now let's look at an arm x-ray. It's only a small portion of that airplane flight. Chest x-ray might be slightly more than that airplane flight, or a portion of it. When we get into CAT scans, that's when we really start seeing larger doses. So while I wouldn't recommend sending all your children for CAT scans, an extra arm x-ray or two to get a better view or better understanding of what their problem is certainly most would consider worth the radiation dose, and really quite minor compared to the usual yearly exposure seen by people on planet Earth. A couple great references to possibly write down. These can be really helpful for you and your patients. The Pediatric Orthopedic Society of North America maintains this website called orthokids.org and contains really useful basic information about a lot of common and even pretty rare diagnoses in pediatric orthopedics. Similarly, Global Help, which is an international community, maintains a similar site called pedorthoacademy.org. This contains a lot more detail and references, and may be helpful if you, as providers, have more interest in some of these topics. I want to thank you all for your time and listening today. I am always happy to answer questions, see your patients for any of the issues we've described. Thank you very much.
Thank you, Dr. Gibly. That was outstanding. Your example of radiation was fascinating to me. And thank you for sharing that. It was this was a great presentation. Yes. And what I like to do now is am I showing the slide right now by any chance for your contact information?
I don't see your slide.
Okay, it'll show up soon, I hope. But if not, it should be. I apologize to everybody. But we'll just
that
go
might
ahead.
also be me.
Yes, why don't you go ahead and turn your screen off?
Okay, there we go. All right.
Okay. So thank you everybody for joining us today. So there are several questions for you, Dr. Gibly, that I would like to present. We have a very active panel today. So we're going to start with Walter Perez, and he says, what is the role of weight on blunts?
So that's an excellent question. We don't really know how much weight causes blounts, since most overweight children do not have blounts, obviously by a very large margin. We do know that many children with blounts have significant weight abnormalities, but we do see children that are completely within normal weight classes that also have blounts. And so the thought is that while excess weight may increase the risk of blounts, it's probably more likely something underlying that physis, the growth plate, that has to do with the development of blounts, and the weight is a contributory factor, but not really the primary driving force.
Okay, great. And then we have a question in from Julie Kalkbrenner. Imaging for a patient that has obvious length discrepancy, do you recommend sending images with patient referral, or do you prefer to do them?
That is a great question. I always love getting images because sometimes you have older images than I can obtain, and knowing what the patient looked like a year ago can be really helpful to decide what's going on today and what is that patient's trajectory. That being said, I understand sometimes the x-rays aren't obtained quite right, or they don't have calibration, or they miss a component of the patient's limb. I am never sad to get extra x-rays, but if you're not sure what to order, you can also send the kid and we'll take care of it.
Excellent, thank you. And then from Angenia Stieber, she asks, would the lengthening be something used in post-Perthes for leg discrepancy?
Great question. Yeah, so Perthes disease is a very challenging diagnosis. Avascular necrosis of the femoral head frequently leads to hip issues and the subsequent leg length discrepancy. Leg lengthening is a pretty big commitment for the patient and family, even with the newer rod technologies. So we rarely employ it for differences that are less than 4 centimeters. I would say that most children with Perthes disease probably don't quite get into that range of leg length difference, and so are probably more appropriate for epiphysiodesis or slowing down of the other side to even them out. And that being said, every family's decision-making process is a bit different, and certainly if they're on a slightly higher range of leg length difference, lengthening rods would be a consideration.
Excellent. And then Julie Kalkbrenner writes again, what are the criteria for length rods?
Oh, that's good. So similar. So there's a lot of technical components of that, which have to do with the ability to get a rod into the bone. So a severely deformed bone may not accommodate a rod and may not qualify. Also, the amount of deformity has to mostly be length and less about angles, although we do have the ability to correct angles at the same time to some degree. The biggest difference is growing rods are pretty hard to use in young children because you have to go through a growth plate. So we rarely use those in children under 10 to 12. And again, for a leg length difference of probably a minimum of 4 centimeters.
Okay. Well, that looks like the only questions we have left, unless anybody else have anything else they want to type in. And I'll give you a moment to do that. And while I do that, I'm just going to thank you all for joining us. And thank you, Dr. Gibly. And I just want to remind you all that Dr. Gibly sees patients at our main hospital, at the Lurie Outpatient Services in Grayslake, Northbrook, and Lincoln Park facilities. You could contact Dr. Gibly at 312-227-6190. For scheduling, 312-227-6510. You can email him at rgibly@luriechildrens.org. He's also available at Rapid Connect or Epic in Basket. And just a reminder that we are presenting at 12:30 today, Dr. Greg Finlayson, as he'll be discussing OCD. And then we will have other presentations today at 3 o'clock, 4 o'clock, and 5 o'clock. If you can't join us, we will be recording all the sessions and sending them out. I encourage you to share it with your colleagues, and for you practice managers who are joining us today, I hope you can share the recordings when you get the link later today with the rest of your team. But other than that, Dr. Gibly, would you like to say anything before we leave?
I just want to thank you for your time, Chad, for setting this up. I'm happy to see your kids far and wide. I see 1-week-olds and 22-year-olds and everything in between. So reach out anytime you need help.
That's outstanding. Thank you so much. Everybody have a great day, and we'll see you later on today.
Thank you all.